Today we are going to try and answer the question, what is a granuloma? And I'm hoping that this question comes from two major kinds of audiences. One is you might be a patient who's been told by a doctor that you have a granuloma in your lung, a granuloma in your skin, and you're wondering what is a granuloma? Or you might be a medical student and you've just begun to read about granulomas and be introduced to them and you're still wondering what is a granuloma? I am very interested in granulomas. I am a lung pathologist. I look at granulomas nearly every day. And I wrote a paper in 2010 with Dr. Anthony Gall from Emory University School of Medicine. And that paper became very popular for people who were trying to understand what granulomas meant, especially in the context of lung disease. So I would encourage you to read this article. It's free and full text in the Archives of Pathology and Lab Medicine if you are interested in further details. But we'll cut to the chase and go straight to the definition. A granuloma is a compact collection of epithelioid histiocytes. Now that's really a mouthful, but if you think of it, it's just like a bunch of grapes. It's a compact collection. That means it's bunched up. It's not just single grapes scattered here and there. And each grape, you should think of that as an epithelioid histiocyte, which is just a kind of cell. So it's just a compact group of a specific kind of cell, and why it forms and what it looks like is the subject of this presentation. So I want to touch on two concepts here. One is inflammation and the other is granulation tissue, because people seem to be confused as to whether granulomas are a type of inflammation or granulation tissue. So let's tackle inflammation first. So the answer is yes. Granulomas are a kind of inflammation because inflammation is when cells respond to some kind of injurious stimulus and try to heal it or respond to it in some way. And epithelioid histiocytes are a kind of inflammatory cell. So yes, granulomas are a kind of inflammation that the body is trying to use to respond to a noxious or injurious stimulus. The other thing that I've looked at and seen in especially on the internet is people say granulomas are a kind of granulation tissue. Granulation tissue. It sounds similar, granuloma, granulation, but it's absolutely not related to granulomas. So granuloma is not the same as granulation tissue. Actually, I think if you Google granuloma, the first thing that shows up is Google gives you a definition saying it's granulation tissue, which is completely incorrect. So granulation tissue is a mix of inflammatory cells, neutrophils, lymphocytes, so forth, with lots of capillaries and fibroblasts. It's the kind of thing that you get when you scratch your arm and then it bleeds and then you start getting this kind of proud flesh appearance. So that's when the skin is healing and making the usual sequence of wound healing, and that's called granulation tissue. And a granuloma has nothing to do with that. So that's completely incorrect. Now I want you to keep this sole of a slipper shape in mind as we talk about what granulomas are, and we'll come to this at the end. But I want to show you where these epithelioid histiocytes come from. So let's start with an artery. So I'm trying to make an artery here, and in the artery, which is a blood vessel, there are of course red blood cells, but then there's another kind of cell in the artery. Let's make it cytoplasm with orange, and let's make its nucleus with blue. So there is a kind of cell called a monocyte, monocyte, and that monocyte can migrate out of the bloodstream, so come out of this artery into the tissues. And when it comes into the tissues, again, it has a lot of cytoplasm, and then it has a nucleus that's either round or slightly kidney shaped. And this cell can be called a macrophage. I'm going to write on this. I'm sorry, this is a laptop, so I'm not writing with any kind of pen. I'm writing with my finger. So please excuse the handwriting. This can be called a macrophage, big cell, phage eating, a big cell that eats, or histiocyte. Histio meaning tissue, cyte meaning cell. And the important thing to remember is macrophage is the same as histiocyte. So whether you call it compact collection of macrophages or compact collection of histiocytes, it's equivalent. as far as I'm concerned. But where does the epithelioid come into play? Now, epithelioid is the look that macrophages take when they encounter a specific kind of antigen. And let's take, for example, let's assume that this macrophage ran into a bacterium called Mycobacterium tuberculosis. In that case, this macrophage would become activated, and its nucleus, instead of being that kidney shape or kind of a round shape, would become elongated like this. And these cells would then be haphazardly distributed like this. And instead of, so these are all nuclei, and instead of the cytoplasm being well defined like it was in the regular macrophage, it'll just be distributed in the background as this kind of orange haze or pink haze in real life, without any well-defined cell borders. Now, why this cell is called epithelioid, this particular cell, why it's called epithelioid, is because it resembles or mimics an epithelial cell. So that's why they're called epithelioid. In fact, this is true. I've seen that when medical students or first-year pathology residents look at these cells, they often mistake them for epithelial cells and then think that this is maybe cancer or carcinoma. But in fact, these are just histiocytes that are bigger and sort of haphazardly distributed. And the shape of this nucleus is very similar to the shape of the sole of a shoe or a slipper. And this collection, so to summarize what a granuloma is, this collection of epithelioid histiocytes, this compact collection, is a granuloma. So why is it so complicated? Why do you need all this to happen? And I'll come back to this in a second to tell you why this is happening the way it is. But it's very important to define the structure first. I'll also make another point, is because these cells can only be seen under a microscope, usually by a pathologist, because these cells can only be seen under a microscope, and a granuloma can only be truly seen under a microscope, it's such a small structure, pathologists are the only ones who can truly say if a patient has a granuloma. Now, radiologists can see granulomas when they become very big, or granulomas that are, for some reason are big enough to be visible on an imaging study. But they certainly cannot be sure that the cells in them are epithelioid histiocytes. So when a radiologist says something is a granuloma, the radiologist is guessing. The guess could be very good based on radiologic findings, but it's never as good as looking at the cells under a microscope. The third actor is, of course, your doctor, the primary doctor who sees you, the clinician, your pediatrician, your internist, your family doctor. These doctors are even less able to say whether something is a granuloma or not. Now, they can tell probably from your symptoms whether you have a disease where you're likely to form granulomas. Maybe they can do that. It's very unlikely they would be able to do this without imaging findings. But even if they do that, they cannot actually see the cells within the granuloma. So really, a granuloma is a very, very specialized structure where you do need a pathologist to confirm that this lesion is actually present. So that's my spiel about granulomas. One thing I will mention, so let me make another diagram here. One thing I'll mention is that as you look at this haphazard collection of epithelioid histiocytes that's pretty compact, you know that is a granuloma. But sometimes, instead of these cells staying like that as a sort of syncytium, they merge together into one big cell. And that big cell contains many nuclei within it. Some of them are epithelioid, some of them are less so, but there are many nuclei. This cell is called a multinucleated giant cell. This is not a granuloma. Although these cells can be seen in granulomas, certainly, granulomas can have multinucleated giant cells in them, adjacent to them, but a giant cell is not the same as a granuloma. And you can see why, because the granuloma is not one cell made up of many cells. It is actually many cells just compacted close together. The other thing I want to make clear is, although textbooks will often show you lymphocytes, so they'll show you a layer or many layers of lymphocytes which are also inflammatory cells, around a granuloma. Sometimes they show you multiple layers of lymphocytes. Lymphocytes are actually not needed for the definition of a granuloma. So even if you had 0 lymphocytes, you could still structurally define a lesion as a granuloma. Now, are lymphocytes involved in the pathogenesis? I mean, do they cause the formation of granulomas? Yes, they're probably involved in recruitment of the macrophages and so forth, and are involved in some way in the formation of the granuloma itself, but they are not necessary for the definition of a granuloma. So let me show you a real picture of a real granuloma stained with hematoxylin eosin. So this is a compact collection of epithelioid histiocytes. This patient had sarcoidosis, and the picture is of a granuloma in the lung. And I'm going to show you a few of the epithelioid histiocytes. Now let me pick out some classic ones. So there's one. Let's see if I can find another really good one. This is a nice one, an epithelioid histiocyte. There's another nice one there, a classic one there, another nice one here. So the point is that the nuclei, the soul-shaped nuclei of these cells is characteristic. Note that in this granuloma there are no lymphocytes, or very, very few lymphocytes, and certainly no multinucleated giant cells, yet this lesion is a granuloma. And we'll come back to this concept later, but this is a form of granuloma called non-necrotizing, meaning that there's no cell death going on in here. Here is a different kind of stain. This is the kind of stain that a pathologist known as a cytopathologist will see, and it's called Diffquick. A variant of this is called Giemsa, or there are several variants to this stain, but the idea is the same. All of these cells are epithelioid histiocytes, and they're clumped together in this tight clump, and therefore this lesion is a granuloma. So again, let me highlight a few. That's an epithelioid histiocyte. This is just spectacular. Epithelioid histiocyte here. There's some very nice ones over here, and they're grouping together to form this compact collection of epithelioid histiocytes. Now, just as an aside, if you look at these cells up here, the ones with that fuzzy stuff on their head, these cells are not epithelioid histiocytes. These are actually ciliated respiratory epithelial cells. These are normal cells of your windpipe, or of the air passages of the airways, of the bronchi and bronchioles. Those are not epithelioid histiocytes. But these other ones, this whole lesion, in other words, this whole ball is a granuloma. Hopefully that's clear. Now in this lesion, this is also from sarcoidosis. This part of the lesion that I'm outlining here is the granuloma. That's a compact collection of epithelioid histiocytes. And these structures over here are multinucleated giant cells. Are the giant cells part of the granuloma? I'm willing to accept that. But the giant cell itself is not the granuloma. The granuloma is the rest of the cells, tightly compact together. Now let's go back to the original question as to why this actually happens. Why do these granulomas form, and what is it that stimulates their entry? So let's go back to the TB bacterium. So this is a kind of bacteria that enters when you inhale TB bacteria in the air that have been coughed out by somebody else, and then that goes into your lungs. So one of the things that happens when a foreign agent comes into the lungs is that the first responders, or cells that are first responders, respond first. So you'll first get a neutrophil, you might get lymphocytes, you might get macrophages. These cells will come and try and attack these cells and these bacteria and try and destroy them. But when the first responders are unsuccessful in killing off bacteria, when it doesn't work, in other words, when the antigen is very difficult to kill by standard inflammatory cells, that's when you need epithelioid histiocytes to come into the picture. So what happens at that point is that the big guns come in, and the big guns form these this kind of palisade of cells all around these mycobacteria, or these TB bacteria, and they surround them and they attack them. So there's kind of there's an inflammatory response going on here, but now you've brought your bigger fighters into the fight. And eventually what begins to happen is that the antigen begins to die off. In other words, some of them get killed and disintegrate. And as they disintegrate, some of the cells also get killed, and you get this thing called necrosis or cell death. Now another one, let's kill off this guy here, and there's cell death here. Let's kill off this cell. So there's a lot of cell death going on in the middle of the granuloma, and eventually this forms what's known as a necrotizing granuloma, because the cell death, another name for that is necrosis. So that is really the point of the granuloma, is to try and attack and kill and disintegrate the antigen that it was going after. So necrosis is really what you want to happen. But remember, all this is happening in a normal tissue. So it's happening in, let's say, your lung or your skin or the covering of your brain or in your eyes. And while this cell death is going on, normal tissues are being killed off too. So this is causing damage in tissues. So it's not a good thing to happen. But it's a better thing to happen than for the bacteria to be killing off tissue. So in a sense, there's a trade-off between letting the bacterium cause havoc and causing some havoc of your own in the attempt to kill off the bacteria. So that's what the granulomas are doing. In other situations, so let me take just one other situation, in a disease called sarcoidosis, for example, that I've been talking about. The antigen is really unknown. So although you've got all these granulomas forming these compact collections of epithelioid histiocytes, forming these ball-like structures in the lung, nobody has been able to figure out what the antigen is. So there is a granuloma. There certainly has to be an antigen. There was an antigen, but we are not sure what that antigen was. So we see these, balls of epithelioid histiocytes, compact collections, but we have no idea what they're actually going after. So this is a very peculiar situation, but it does lead to a well-defined, definable disease that can be treated, or at least we can attempt to treat it and know something about its natural history and symptoms, even though we don't know what really instigates these epithelioid histiocytes to come in. Now, what does that look like to a radiologist? Now, when all these granulomas ball together and make a bigger ball, eventually the ball becomes big enough that a radiologist can see it on a chest CT. So that the smallest of these little dots in the lungs are the ones where the granulomas have become confluent. And here you can see at the periphery that even those small, big granulomas are merging with each other to form even bigger granulomas. So radiologists can see the cumulative effect of several granulomas making a big, confluent structure. But again, radiologists cannot see individual granulomas for the most part, and they certainly cannot see individual cells. So they are, even at the best of times, they are guessing when they say something is a granuloma. And there are features like in the lung, for example, calcification, association with other features, splenic calcifications and so forth. There are things that can give radiologists a clue that a lesion is a granuloma, but they can never be 100% sure without a pathologist looking at the tissue. Now here's an example of what could have looked like, could have given the radiologic impression that I showed you in the previous slide. So there are literally dozens, if not hundreds, of granulomas in this lung. So if I can highlight it here, this part here is the normal lung, the lung that doesn't have granulomas. And then pretty much everything else is granulomas and the fibrosis or collagen deposition that's associated with them. So these are all granulomas merging together. These are granulomas merging together. The pink in the background is collagen or fibrosis that is accompanying the granulomas. Again, this is a case of sarcoidosis, and you can see why this can be a very striking disease both clinically and radiologically, is because there's so many of these inflammatory cells accumulating in the target organs and causing problems. We've already talked about the concept of a necrotizing granuloma. One point I wanted to make here is that as the necrosis that we talked about before, let's just make the bugs again. So let's make a bug here and another there, and let's make a lot of necrosis, let's say, has occurred in this lesion. So lots of bugs have died, lots of epithelioid histiocytes have died, a lot of the lung tissue has died. So it's really a big, big mass of necrosis. Where are the epithelioid histiocytes at this point? Well, they've been pushed out to the periphery of the lesion as the necrotic center grows, as the detritus and debris of war accumulates in the center of this lesion. The actual epithelioid histiocytes get pushed to the periphery. And at that point, the granulomatous area of this granuloma is here, and the necrotic area of the granuloma is there. So this lesion is known as a necrotizing granuloma. And why I mention it is the necrotizing granuloma is the classic inflammatory response to mycobacterial diseases like TB, like non-tubercular mycobacterial infections like MAI or MAC, and also to certain fungal infections like histoplasmosis, endemic in many parts of the United States, coccidioidomycosis that you get in Arizona and New Mexico, in Southern California, cryptococcosis that you get pretty much the world over, and blastomycosis that you get in some parts of around the Great Lakes. So there are at least 4 major fungal diseases where the classic inflammatory response in the human body is to form, at least in patients who are immunocompetent, is to form granulomas that are constantly trying to kill these organisms as their means of defense. Now here's a picture of a necrotizing granuloma, and as I showed you before, the necrotic center is in the middle of the lesion, actually forms maybe by volume the bulk of the lesion, and the granulomatous rim is at the periphery of the lesion. So here is the granulomatous rim. These are the granulomatous epithelioid histiocytes. But what catches your eye often is the multinucleated giant cells. And so I don't fault people for using multinucleated giant cells as a surrogate to say that there's a granuloma nearby, but a giant cell, again, is not the same thing as a granuloma. Here's another beautiful example of a necrotizing granuloma. It's very low magnification, so you can't really see the cells here, just the central necrosis. But believe me, the cells in the rim here, if you look at them at high magnification, are all epithelioid histiocytes. So this is a necrotizing granuloma. And often in the necrosis, not always, but often in the necrosis, if you look carefully and do special stains that will bring out microorganisms, you will find microorganisms. In this particular case, we did this stain called a Grocott methenamine silver, or a GMS stain, which is a special stain for fungal organisms. And you can see all these little black things are fungal yeast, and this is actually a fungal organism or bug called Histoplasma. It's very common in Ohio, where I practice, but also in many other parts of the United States. So this particular necrotizing granuloma was caused by histoplasmosis, and that's a very common scenario in this part of the country. When a lesion like that is removed by the surgeon, the granuloma can be seen with the naked eye, or at least the sum total of the necrosis and the granuloma and so forth is visible to the naked eye. And that's what it looks like. So this whole lesion here is the granuloma, and this is the lung around it. So this is the uninvolved lung on the periphery. This structure up here is the pleura. So that's what a granuloma looks like to the naked eye. Like if you saw it without a microscope and it was big enough to see, that's what it would look like. And then this lesion looked like this on the CT scan. So this is the right lung, that's the left lung. This is anterior or forward. This is backward. And then this is the windpipe that you're seeing here. This lesion that I'm circling now, let me just circle it with a different color so it stands out. So this lesion, the white lesion in the center of the circle, is a nodule or a little ball that's formed within the lung, and that's what the granuloma looks like to the radiologist. So often radiologists can't even tell whether something is a granuloma or might actually be lung cancer, and for that reason these lesions need to be biopsied. A piece of tissue needs to be either taken with a needle or a forceps, or the entire lesion needs to be taken out by a surgeon so that a pathologist can look at it and figure out that this is actually a granuloma. So I will come back And summarize what we learned about granulomas today. A granuloma is a special kind of inflammation which forms a compact collection of epithelioid histiocytes. Thank you for your attention.